Today, we will be having our session will be on introduction to pain, which will be taken by Dr. Savita Butola. She's a commander and chief medical officer, Border Security Force, Pansara, Tripura. And she has been she's an honorary senior tutor in Cardiff University, honorary secretary for Indian Association of Palliative Care, and founding member of eHospice India, and national faculty for IAPC, APHN, and expert member with Ministry of Health and Family Welfare for NPPC. She has multiple publications and received several recommendations for her pioneer work in palliative care. Over to you, madam.
Good evening to all the participants, and thank you very much for the introduction. So I hope you are having a fresh mind now that we are going to start a very important topic. So I'll just go on to my screen. Shripriya, can you see it now clear?
Yes, ma'am. We are good.
Okay. So today we will be talking about pain, how we assess it and how we manage it. Pain, as we understand, is a part of our life, and it's a part of human existence, they say. But what is the definition? The definition has been revised by the International Association of Study for Pain in 2020. And it is now defined as an unpleasant sensory and emotional experience, which is associated with or resembles that, which is associated with actual or potential tissue damage. So all parts of this definition are important. It's very important to understand that pain is a very individual experience, and it's a biopsychosocial experience. It's not just a physical experience. Nociception and pain, as we understand, are two different things. And pain is not something felt just by the sensory neurons. Pain is something felt by an individual through the experiences that they have had in their life. And whatever the patient says, we accept it as their experience of pain. And although it is an adaptive function of the body, it tells us that there is something wrong and that the body has to take some action to prevent tissue damage. But overall, when you look at the person, it has some kind of adverse effect on the social function, on the psychological well-being of not only the person, but also the family, the caregivers, and the community as a whole. So verbal description is just one of the ways in which pain is communicated or told. But if a person is not able to communicate that pain, or if it's a non-human living being, it doesn't mean that they do not have pain. What is the extent? Why do we talk about pain so much? Pain in palliative care forms the main entry point for most of the patients. And if you look at the disease burden, almost 2/3 of the cancer patients have pain. And out of the ones that do have pain, 1/3 will have pain at one site, 1/3 have pain at two sites, and 1/3 will have 3 or more different kinds of pain. Out of the patients who have HIV, 25% of asymptomatic patients, almost half of the ambulatory patients, and almost 80% of patients hospitalized with HIV have pain, but not many of us would think of pain as being associated with HIV. Similarly, patients who are in heart failure, almost half of them, half of the CHF patients also have a lot of pain burden. But pain is important not only just because it interferes with the quality of daily life, but also because it increases the existential distress and also because it increases the risk of suicide. The important thing is that pain remains unacknowledged all over the world. It is not adequately assessed, and therefore it is not adequately treated. There are less than 4% patients who get adequate relief, and as much as 85% of the pain is because of the disease, but 15% is what we give to the patient in form of treatment, because of radiation, because of chemotherapy, because of the side effects. And there are many studies to show that pain is not properly acknowledged and treated. There was one study by Grossman which showed that almost 73% of the cases were not adequately assessed and appreciated by oncology fellows. And whatever figures we look at, there is no study or no data which can quantify the amount of suffering that patients and families have as a result of untreated pain. Now, in the introduction, which you already must have had, you must have learned that Dame Cicely Saunders was the one who gave us the modern palliative care medicine. And she said that there are 3 dimensions of pain. Pain is just not physical. Pain is spiritual. Pain has a psychosocial and emotional component to it. But when we classify pain according to the duration and the nature, we see that pain can be classified by duration as acute and chronic. And by the nature, it can be classified as nociceptive and non-nociceptive. Nociceptive pain can further be somatic and visceral. Non-nociceptive pain can be neuropathic and sympathetic. Now, you have all studied this in part of your physiology classes and medicine classes, but we will just briefly touch upon the things. Somatic pain can be because of receptors which are present in the skin, soft tissues, and bone. And the visceral pain can be because of the capsules, the bowel, or it can be cardiac pain. The nature of the pain in all these cases is slightly different. In somatic pain, the pain can be felt as aching, superficial, or dull as well as sharp. In case of capsular pain, the patient will tell you that there is stabbing or burning or gripping pain. And if there is the bowel involvement, the patients may feel dull, cramping, or colicky pain. Cardiac pain can be tight, squeezing, choking, and the neuropathic pain patients will say that it is stinging, electric shock-like, shooting, or they complain of burning and numbness. Now, when we talk of neuropathic pain, most of the cancer patients that you will see and most of the cases that come to us in palliative care have mixed pains. So it's not just a one clear-cut kind of pain, but neuropathic pain can be because of many reasons. It can be spinal cord compression, it can be neuroma, it can be nerve infiltration in cancer. And the most common pain that we see in our practice, neuropathic pain, PIVD, as well as the diabetic neuropathy pain. Then how do we classify according to the duration? Pain can be acute, it is transient. Any pain which lasts more than 3 months is called as chronic pain. And as you can see here in the table, the acute pain usually indicates underlying tissue injury. It is self-limiting, and as the body heals or the trauma heals, the intensity will reduce. This is a protective symptom which tells you that there is something wrong in the body, there is some tissue damage, and some action has to be taken. So post-traumatic pain, post-surgical pain, these are the pains which are acute. And what about chronic pain? Chronic pain is the one I said lasts more than 3 months. It is a multifactorial kind of pain. It causes permanent neurochemical changes in the body. What are the differences apart from these? When you think of acute pain, you will think of a patient crying, writhing. Think of patients who come in the emergency with a renal stone. They will be crying, they will be having nausea, they will be rolling around, groaning, sometimes shouting. But what about the patients who have chronic pain? They will not be having the classical symptoms that we associate with pain. So redness, heat, swelling, these may not be there in the chronic pain, and patients will be lying quietly in a corner. So maybe the cancer patient you see in the ward who is lying on the bed with the face towards the wall, not talking to anybody, not complaining, not saying anything, is the patient who has the maximum pain. But we are trained to think of pain only in terms of a patient making noises. So we generally think that if a patient is not making a noise or a halla, then the patient is not having pain, which is not true. In chronic pain, it is the vegetative responses which predominate. So patient will have decreased appetite, decreased sleep, decreased libido, decreased social interaction, and might be associated with depression. These changes are progressive because the underlying disease is not going away in a chronic pain. So for the patient, this is a constant reminder of his life-limiting illness, and the pain itself takes on the characteristics of a disease. When you put on a perfume, when you're going out, you put on some perfume, but what happens is you get the smell for a while, and after say 5 minutes or 6 minutes, you will stop smelling that perfume yourself. What happens? Your olfactory, your nasal receptors, they get used to that smell, they adapt. But the difference is that in case of pain receptors, now this is very important to understand chronic pain. Pain receptors do not adapt over time. So what happens is that chemical changes occur. There is sensitization of the receptors because of prostaglandin secretion. This leads to sensitization of the dorsal horn cells, NMDA receptors, because of which the receptors which are present around the area of injury also get activated. Then the spinal segments which are around that spinal segment which carrying the pain for this particular injury, they also get affected. And there is also change in the inputs from the brainstem. So all of these things lead to worsening of pain. It increases, it goes on increasing in intensity as well as severity as well as extent. This is called as the winding up phenomena. So this will keep happening in a patient having chronic pain unless and until you give them proper assessment, you give them proper treatment, which will break this cycle of pain. So how do you evaluate a patient who complains of pain? History is very important. Now, practically what we see is that with the change that is coming in now, with the practice of medicine becoming more and more investigation based, the younger generation is putting less stress on history taking skills. But please remember, in palliative care, in pain assessment, history taking is very important. So you have to take a good history, look at the records if they are available, see what all has already been done, what treatment has been given, what are the investigations which the patient has already had. Because if we blindly order investigations, first of all is the need for those investigations. Are they really going to change the management of the case? It is said that a good doctor is the one who will order investigations only if they change the management. So a person with a diagnosis that is already there, patient who has already been treated in a number of places, might not need a full battery of investigations. So be very choosy when you write investigations for these patients. See what is important, and only if it is required, then you advise. Then confirm the site of the pain, do a good physical examination, identify the cause. And when you are taking a good history, when you are talking to the patient, when you lay your hands on the patient to examine them, it will help you to establish a good rapport and a good trust. That is half the thing done when you are looking at a patient for pain. I'm sure you have all been told that pain is now called as the fifth vital sign, besides the 4 vital signs that we already know of. So stepwise evaluation is important, and it is important to make a change in your hospitals by incorporating pain in your routine assessments, in OPD charts, in the indoor charts, in the vitals chart for your staff. And when a patient comes in severe pain, do look at the pain, look at the patient and start managing during evaluation, because if a patient is coming in severe pain, it's an emergency. Then we do not waste our time on detailed evaluation right then. We treat and simultaneously we take history. So please remember, an untreated pain, a severe untreated pain is an emergency. So for a routine patient, we also use checklists, QL, that is quality of life measurements, prioritize the problems as per the patient's history, and use tools. So we will come to the tools in the next slides. When you assess pain, these charts are very important. So the factors that we assess, PQRST, what makes the pain better, what makes the pain worse, that is palliative and provocative factors. What is the quality of the pain? We ask the patient to describe the pain. Is it stabbing? Is it burning? Is it squeezing? Then Does it go anywhere from the site of pain? Which part of the body is affected? Where does it go from that site? Then what is the severity of the pain? We will come to it, how we assess severity. We generally ask them to describe it. Is it mild? Is it moderate? And we ask them on a number scale of 1 to 10, how much is the pain? How does it change over the day? Is it more in the morning? Is it more at night when you are sleeping? Is it better when you are sitting? Does it get affected by food? All these things that we learned in third year to take history properly regarding the pain. But some assessment tools are there which you can use. So there are unidimensional scales and there are multidimensional scales. So unidimensional scales include visual analog scale, numerical rating scale, verbal rating scale, and faces scale, which we use for children. Then there are multiple other, I have just listed them here. McGill questionnaire, brief pain inventory. These are for somebody who's more interested in reading about it. You can go and read all these. Memorial pain assessment card, Edmonton symptom scale. There are many of them which are used for tertiary centers. These are used for research work also. But this is something very useful that we use in the OPD with children. This has got faces made on it, and you can take a printout, laminate it, keep it in your OPD, and when you assess children, you can just show them this and find out how much is the pain. So a child who's more than 5 years, 4.5, 5 years can easily tell you how much is the pain depending on the faces which are here. This is a smiley face, means no pain, and the worst possible pain is a crying face. So children are very easily, they can tell you how much is the pain they're having. This is a numerical rating scale. We ask them from a scale of 0 to 10, they have to tell us how much is the pain. So any pain from 0 to 3 is rated as mild, 4 to 6 is moderate, and more than 7 is severe pain. Sometimes you may have uneducated, illiterate patients or ladies who are not able to tell you how much is the pain. For them, in India, we use a rupee scale. It is very helpful. So ask them, out of a rupee, how much is the pain? Is it 50 paisa? Is it 25 paisa? Is it rupee out of rupee? So this is something patients practically are able to tell better than even the numerical rating scale. Then further evaluation, we have asked about the site, we have asked about severity, radiation, what is the character, what makes it better, worse, and what is the impact on your life? How does it affect your life? Are you able to do your daily activities? Are you able to dress yourself? Can you walk? Can you go for work? Can you cook for yourself? Can you do your hair? Can you raise up your arms to do your hair? So these are things that help us to assess the impact on their life. This I have taken a picture just to show how the detailed assessment of pain can be done and how it affects the general activities, mood, walking ability, relation with other people, sleep, enjoyment of life. Everything can be rated from 0 to 10. These are other forms. Here we have a body chart. A body chart is very helpful to have on the assessment charts because we give the pencil to the patient and we ask them to shade up the parts where they are having pain. So it will help you not only to find out whether the patient has pain in more than one site, it will also help you to find out which are the dermatomes which are involved. So this is another way of, assessing the pain. You can see these in detail, record other symptoms like nausea, vomiting, any interventions they have had, then where to refer. All these things are listed so that we do not miss out on anything when we are assessing the patient. Then also find out what is most distressing for the patient. So patient may be having pain, but may be more distressed by the fact that he cannot go to the toilet alone at night. And he's afraid of passing urine in the bed. Document whatever you have asked, make a proper plan, and also follow up regularly. So this is a regular follow-up form which we have. I'm just switching off my camera because my voice will go otherwise. So this is a follow-up form. I will come to it later. When we call the patients again for assessment after starting the treatment, it's very important to document all the details of the patient. So I have put them on the slide so that you can use them if you require in your institutions. What is the aim? When we manage a patient with pain, the main aim is not only to optimize the pain control, but also to balance it with the side effects they may have because of analgesics and enhance their functional abilities to ultimately to improve the quality of their life. And the guidelines are go by the WHO ladder. I will come to the ladder in a minute. By the mouth, by the clock, for the individual with attention to detail. Means the treatment has to be individualized and regular medication is required for chronic pain because the pain is not going to go away after 4 hours or after 2 days. The pain is going to be there. So these patients will require round the clock medication. Now, this I want you to see very carefully, this slide. This is the WHO analgesic ladder. This was given by the cancer unit of the WHO way back in the 80s. And they say that proper use of this ladder can help us to relieve almost 80 to 90% of the patients who have severe pain. Though it was given for cancer, it can be useful for other diseases also. And there are 3 steps. The step 1 is for mild pain, where we give non-opioids and adjuvants. So what are adjuvants? Adjuvants are drugs which are not themselves analgesics, but help us in controlling pain. So we give these medicines and see for 24 hours. If the patient's pain is not better, we go on to step 2. Step 2 has mild opioids plus step 1. That is mild opioids, and you can give non-opioids and adjuvants also. If again after 24 hours the patient is not improved, we go on to step 3. Step 3 has opioids and non-opioids and adjuvants. Now, non-opioids were here at step 1. So important thing to remember is that we do not combine the drugs at step 2 and step 3. Recently, a step 4 has also come in to the WHO ladder, which is the interventional pain management. So these were the drugs which were given at step 1, 2, 3. Let me go back and show you non-opioids, mild opioids, and strong opioids. So non-opioids, weak opioids, and strong opioids. So this is step 1, this is step 2, and this is step 3. For mild pain, we start with NSAIDs, paracetamol. For pain which is moderate, we try to give weak opioids. Try step 1, then go on to the weak opioids like tramadol, codeine. If this doesn't help, we go on to the strong opioids, morphine, buprenorphine, fentanyl. Now, these are the opioids which are available in India, but in Western countries, there are many more. Hydromorphone, oxycodone, there are lots and lots of options that the Western countries have, but we do not have access to those. So I have listed only the drugs which are available in India. Adjuvants, I was telling you, adjuvants are the drugs which are not themselves in analgesics, but they help in controlling the pain. If a patient is having pain because of repeated vomiting, gastric ulcer, antiemetics and PPIs will help. If a patient has severe muscle cramps or muscle spasm, as children may have in cerebral palsy, muscle relaxants can help. A patient who has not slept well because of pain for a number of days can be helped if you give them anxiolytics or sedatives, and patient can sleep well to break the pain cycle. So all these drugs, antidepressants, anticonvulsants, we will come to them. They are very helpful for neuropathic pain, muscle relaxants, antibiotics if a patient is having pain because of an infected wound. All of these drugs are the ones which can help us in good pain management. How do we select NSAIDs? For mild to moderate pain, we generally start with the lower drugs, start with paracetamol. You may have pain associated with inflammation, and there may be comorbid conditions like rheumatoid arthritis, osteoarthritis, post-operative pain, trauma. So we start with basic things like paracetamol, brufen, diclofenac, depending on the profile of the patient, the age of the patient. You may have to select COX-2 inhibitors depending on the cardiovascular and renal status of the patient, the age, as I said. We will not go into much of the details. You all are aware of how NSAIDs work. COX-2 COX-2, COX-1, COX-2, COX-3 inhibitors, and their doses are all listed here in case you want to read them back. Diclofenac, ibuprofen, ketoprofen, naproxen, piroxicam, mefenamic acid. These are all selected depending on the GIT profile and the age of the patient. As I said, be very careful in old age for the cardiovascular and renal toxicity of these drugs. And adjuvants. Steroids can also work as adjuvants for pain caused by edema. And night sedatives, especially when the patient has not been sleeping well because of pain. Then neuropathic pain has a slightly different management protocol. First line drugs are the ones which I have listed here. These include antidepressants, anticonvulsants, opioids can help, steroids can help, and radiation can help. And these are the second line drugs: ketamine, lignocaine, Spilin analgesia, TENS, and nerve blocks. This is a chart which details the uses of anticonvulsants for pain, especially for neuropathic pain. Gabapentin, pregabalin, carbamazepine, oxycarbamazepine are all helpful. The important thing to remember is that gabapentin is cheaper than pregabalin, and there is not much difference between their adverse effects. But both of these drugs take time to act. So whenever you start a patient on these drugs for neuropathic pain, please tell the patient that it will be slow in acting. They might have dizziness, they might have sedation, there might be increased weight and appetite, but it will take about 2 weeks to start acting, 4 to 6 weeks to give its good effect. And if you need to titrate, it will take another 2 or 3 weeks. So patient has to take these drugs for 2 to 3 months in order to get the best effect, both for gabapentin and pregabalin. There's not much to choose between them except for the cost. Steroids, as I told you, and I'm sure you're all aware that they are very good for pain management, especially in brain metastasis, to decrease the pressure inside the brain with brain mets, obstructive syndromes, in the spinal cord compression. And also, we must remember that they have to be carefully used in diabetics and patients who are on anti-epileptics. But then there may be some patients, 10 to 15% of patients may be there who are not relieved with these things, and they will need some kind of intervention. So nerve blocks, sympathetic blocks, ganglion blocks, radiofrequency ablation, intrathecal pumps, and peripheral nerve field stimulation, as well as vertebroplasty. All of these can be very helpful depending on the kind of patient you have selected. But since not all of us are from anesthesia background, we should know where to refer our patient. Who is the nearest person, where is the nearest institution where you can refer these patients in case they need to have some kind of intervention for pain management. And now, the second part of our session today, very important part, we will be talking about how to use opioids in pain management. Pain relief, they say, is a fundamental human right, and denial of pain relief by not giving patients access to the drugs which they could have had is as bad as torturing a patient. 6 countries of the world, of the developed world, Australia, Britain, Canada, France, US, and Germany, they consume almost 80% of the medical morphine in the world, whereas the developing countries with 80% of the population consume only 6 to 8%. India is the largest producer of legal morphine, medical morphine, but domestic consumption is very little, although we have a huge number of patients because we are not trained to use it. We are not taught about proper use of opioids in pain management, and domestic consumption remains very small. We are afraid of abuse and addiction more than we are concerned about pain relief. And because of the regulations which Not many of us are aware of how to get it into the institutions. As a result, most of our morphine goes to other countries and our patients do not get it. There was a resolution passed by the UN in 2005, which says that medical use of narcotic drugs and opioids is indispensable for the relief of pain and suffering, and that morphine should be available at all times in adequate amounts, appropriate dosage forms for severe pain, and that low national consumption of opioids is a matter of great concern. Now, how concerned should we be? Please look at this chart carefully. This shows the number of deaths with moderate or severe pain in India. This was given by the International Narcotics Control Bureau. 80% of cancer patients and 50% of HIV patients die in severe pain. Their average requirement of morphine is 679 milligrams. And the actual use in India per capita is only 0.4 milligrams. So you can imagine how much of concern we should have. This is a chart that shows the global consumption of morphine per capita in the countries. Austria, US, UK are here at the top of the chart. And if you look for India, you have to look really, really hard, and you will find India somewhere here at the bottom. India is here. This was given by the Pain and Policy Studies Group of Wisconsin. What is the problem? Why do we not have access? Lack of education and knowledge, number one. Fear of addiction, legal issues. Patients are also reluctant and we are scared of how to use. The side effects may be there. Patients are also reluctant to communicate and talk about pain. Initially, the process of getting a license was very difficult. Paperwork was difficult, and continuous supply of morphine is a problem. And the laws were there, but they were never intended to block relief. However, the fact that we lay more stress on addiction than to pain relief is what has been causing the problem all along. The manufacturers, the pharma companies which are there, they are obviously there to make profit out of whatever drugs they make. So if there is a low demand and the bureaucracy is cumbersome, then they do not have a profit out of selling medicines which are cheap. It's very difficult because it's repeated journeys to the hospital from, if you think of somebody living in a remote area, like I am sitting in Tripura, I am 5 hours away from the nearest hospital. I'm in the middle of the jungle. So if somebody, even if a person in I'm from Border Security Force, a person who has a gunshot injury at the border does not have access to morphine. Can you imagine? We just shift them with Voveran and Tramadol, and that's not enough. So repeated consultations with people who are busy, any detail omitted by mistake on the OPD slip, the pharmacist will send the patient back, and patients stand in line right from 4 o'clock. I've seen in AIIMS patients standing in line from 4 o'clock in the morning, getting one small mistake on their slip and then again being sent back right to the back of the queue at the pharmacy. It's very difficult. And the myths that we all have about the fact that morphine should be used only if patient is dying, it will hasten the death, causes respiratory depression. But we must remember that these are medications like any other medication. So if we can be trained to give insulin, which is more difficult to learn about, if we can be trained to give steroids properly, if we can be trained to give chemotherapy properly, why we cannot be trained to give morphine properly? Important thing to remember is that strong opioids are there to be used, not to be withheld. They have to be given according to the intensity of the pain. Any patient having intense severe pain, more than 7 out of 10, please remember that they need to be treated with opioids. It is not according to type of pain. It is not according to the diagnosis. It is not according to the stage of the disease. But we must learn how to use morphine properly. We always start with immediate release preparations. Now, there are immediate release preparations. There are slow release preparations of morphine. we always start with immediate relief. And we get a proper dose after titration. Only then we put the patient on slow release. And there are side effects. Everything has a side effect. The sugar you use in your food has side effect. The oil you use has side effects. So cover those side effects prophylactically and continue the step 1 drugs, continue adjuvants, continue supportive therapy, and very regularly review the patient. So it's very important to pay attention to detail. Review. Do not forget to review your patient properly. There are different kinds of formulations of morphine. There are immediate release tablets, 5, 10, 30, 60 milligrams strength. There is syrup in some places. Then controlled release tablets are available, 10, 30, 60 milligrams. And in other countries, we have rectal suppositories also, which are unfortunately not available in India. But you can really use the normal release tablets rectally. They have the same kind of profile, pharmacokinetic profile, if you use them rectally. So how do you use them? They act via the mu and kappa and delta receptors to the dorsal horn of spinal cord and also through the brainstem and peripheral nerves. We must remember that the first line opioid is morphine. Normal release morphine is the first line drug. I have seen so many RCCs, I have seen so many medical colleges having fentanyl, but not morphine. Why? Because the MR will come to you and tell you that you give me the address of the patient. I will see that the fentanyl is delivered to the patient, because fentanyl is, how much is it costing? Almost 1,500 to 1,800 rupees for 3 patches. And morphine, it costs less than a loaf of bread. And the pharma companies do not have the benefit that they have by selling fentanyl. So they will push the expensive formulations into the market at the cost of the cheaper drugs. That you have seen in all branches of medicine. We must remember that fentanyl, buprenorphine, these are all second-line drugs. And methadone, which has been now introduced in India, is a third-line drug. But this is to be used only by very few people who are properly trained, as it has got a very long half-life and it's slightly complicated pharmacokinetics. How do we start? When a patient you have seen will come to you with severe pain, or a patient has been given step 2, maximum dose of tramadol not responding, we start with low dose morphine, 5 to 10 milligrams every 4 hours. Now the effect lasts for 4 hours of a normal release morphine. So 5 to 10 milligrams every 4 hours, and then you titrate according to the pain relief. Go back to the patient, ask. If a patient is complaining of pain 8 by 10, start with 5 to 10 milligrams of morphine. Ask after an hour, 2 hours, how much is the pain now? If there is significant decrease in pain, say it has come down from 8 to 6, that is significant. If patient continues to have 8, then you will have to give a slightly higher dose. Increase gradually, only by 5 milligrams. So you've started on 5, patient is better, keep going for 5. If patient says, I have no relief with 5 milligram, next time you can give 10 milligrams. Patient will be drowsy for a while. When you start opioids, patients will have some drowsiness, some sedation, some nausea, vomiting, but we have to start prophylactic drugs for that. Please tell the patient that whatever is told, if they have to be given the drugs 4 hourly, they have to be given 4 hourly. We have to tell our staff, train our staff, and also tell the patients that they may need to put an alarm clock, but the medicine has to be given 4 hourly. Sometimes they will feel the pain relief is now better, they will stop, they will miss one dose and the pain will come back again. So things that you need to consider is the age of the patient, renal and liver functions, extent of the disease, any other concurrent disease, any other concurrent medication. As I said in the beginning, it has to be given by the mouth, by the clock, by the ladder. So regular schedule, you may have to give, like I have shown you here, for example, you give at 6 a.m., then 10 a.m., 2 p.m. Every 4 hours we need to give. So that brings out 6 doses in a day. What happens when the patient is sleeping at night? Supposing this is the 10 p.m. drug, what do? Should we wake them up at 2 a.m. to give the drug, or should we give double? Initially, you may need to wake up just to titrate the dose properly for the first 3, 4, 5 days. And then if the patient is stabilized, you can give double the dose here at 10 p.m. So the patient and the caregiver don't have to get up at night. But always evaluate. When you are starting the drug, it's better to put the patient in daycare or admit. Start the drug, evaluate, titrate, see for the first 2 days, and then send them home. But once you have sent them, please evaluate over the phone or call the patient back and physically examine within a week. If the patient comes with severe pain, patient is coming in a severe pain crisis, we may have to do rapid IV titration. What about codeine? Codeine is converted, it's a prodrug. It is converted by the body to morphine. And usual doses are 30 to 60 milligram, 4 to 6 hourly. The effect lasts for 4 to 6 hours, and it's usually combined with the NSAIDs. We must remember that for chronic pain, pethidine is not a preferred analgesic now. Then what about tramadol? Tramadol is also a centrally acting synthetic agonist which acts via mu receptors. It's a step 2 analgesic. And the dose is 50 to 100 milligrams every 4 to 6 hours. So that the total daily dose is 400 milligrams. You can start with 50 mg TID, you can go up to 100 mg 6 hourly. If the patient is still not having adequate pain relief, we will go on to morphine. But this is to be avoided in children below 12 years. And we must remember that it can precipitate seizures. Rapid IV injections can precipitate seizures, and it can cause seizures in case of a patient who is on antiepileptics. We have to be careful in those patients. Side effects, all these the same as other opioids, but you must have seen that tramadol is one of the most commonly used drugs, especially in orthopedics. For backache, every patient with backache, every patient with PIVD started on tramadol, and that's what is often seen giving tramadol a bad name. So you may have patients who are non-malignant who need tramadol, but the thing to remember is we do not deny them pain relief, but we have to closely supervise. And remember that patients need to be titrated when they are coming back also. You know, when you're stopping the drug, it has to be tapered off like you taper off steroids. Even 5 days continuous use and then suddenly stopping tramadol can lead to narcotic withdrawal symptoms. It's not that you're not going to use it. We are only going to supervise the patient properly. And please make your colleagues aware of this fact that unsupervised use, not giving patient proper pain relief, not following up properly can lead to dependence, can lead to problems, gives the drug a bad name. And it leads to problems with other people who need that pain relief. What about fentanyl? As I said, fentanyl is a second drug. It's a very good drug, but it's a second line drug. It's expensive. It's 100 times more potent than morphine. It is used as a transdermal preparation. It can be used IV, intrathecal, transdermal, epidural, all the ways. These are the drug formulations, 25, 50, 75, 100 micrograms. It is slowly released via the skin, forms a depot under the skin, and then it goes into the bloodstream. So you cannot titrate it. It should be given only after you have found a particular dose for the patient. Patient is on stable pain relief with normal release morphine, only then we convert to the equal dose of fentanyl. So it's not simply starting. You don't start with a fentanyl skin patch ever. And you cannot, the problem is that titration cannot be there. And if patients develop side effects, then you cannot stop the drug also. With normal release morphine, a patient is having side effects, you can stop the drug. It will go out of the body in the next 4 to 5 hours. But with the skin depot preparation, this will take 12 to 24 hours to get out of the body. So this is not used for starting the drug, and you don't use it for patients where you are not sure of the dose. There's also something called OTFC. This is called a fentanyl lollipop. Oral transmucosal fentanyl citrate. It's a lollipop kind of thing which is impregnated lozenge on a plastic handle, available in 200, 300, and 400 microgram units. Effect is very quick, 20 to 22 minutes, but we do not have access because it's very expensive. It's not available in the market, though it's a good drug for sudden pain, for acute and breakthrough pain. We'll come to it. And as I said, these are the pharmacokinetics. If you want more detail, short-acting formulations, they last for 4 hours. Long-acting preparations, controlled release preparations, which affect for 12 hours. But for chronic pain, what is the preferred route of administration? Do we give IM injections? No. We don't give IM injections because it causes more pain to the patient. Every 12 hours, you cannot be giving injections forever. What we prefer is the oral route. If the patient is not able to swallow, there may be oral cancer patients, there may be patients having severe nausea because of chemotherapy, stomatitis, who are not able to swallow. For them, we use IV, subcutaneous, transdermal, or continuous subcutaneous infusion can be used with a pump, but not in routine. We prefer oral continuous or oral intermittent dosage for them. Also for patients who may need, in special situations, they may need sublingual drug for breakthrough pain, and epidural or intrathecal route can be used. Whenever you start a patient on opioids, always warn them about side effects. Sleepiness and dry mouth are the most common things which happen. They will be there for a week, but they will go afterwards. You have to warn the patient and family. Constipation, however, will remain. As long as the patient is on opioids, constipation is going to be there. So we say that the hand which prescribes morphine should always prescribe a laxative. Never start your patient on opioids without giving them a laxative. And if the patient you feel is too sedated or is going into toxicity, then you may need to stop a few drugs and start again on a lower dose. If the patient is not tolerating morphine, there may be patients who don't tolerate morphine, then we can give other drugs. We can go into the family and see if fentanyl is there, codeine is there, or methadone is there. We can put them on other types of opioids. I have listed out all the side effects here. You can see the details: nausea, vomiting, constipation, hallucination, pruritus, and respiratory depression. Now, respiratory depression, we must talk about. It's not common in palliative care. It doesn't happen in chronic pain patients, practically not there. But whenever you put a patient on morphine, if your institution is getting morphine, you must always have naloxone available. Then, why respiratory depression is not there? It's not there because pain, chronic pain, acts as a physiological antagonist to respiratory depression. But there are two conditions where you have to be careful. One is a nerve block, a patient undergoing a nerve block, or a patient undergoing surgery, where that pain stimulus is suddenly decreased in the body. There you have to be careful about the dose, and the dose may have to be decreased. For nausea, vomiting, whenever we start opioids, we always start patients on metoclopramides along with it. For constipation, as I told you, we will start both a softener and a stimulant. So Cramofen and Dulcolex is what we usually use. 15 to 30 ml HS, we can increase it. Dulcolex, we start with 10 mg HS and we can go up to 2 tablets BD or TID. But the important thing is to tell the patient not to stop these drugs, not to stop constipation, because sometimes they can go into retention, and constipation can be more difficult to treat than pain. Please tell them to take these laxatives very, very regularly. We have seen practically that people are very fond of writing lactulose for patients with constipation, but please remember that these palliative care people, the patients who need opioids and pain management, our population is not able to take large amount of fluid, and lactulose will not be able to help these patients. So the way opioids cause constipation is a number of ways they act on the gut, and softener and stimulants are the best to prevent that constipation because of opioids. Do look out for signs of toxicity. These are not common, but you should know: drowsiness, hallucination, pinpoint pupils, urine retention, myoclonus. Be careful of renal failure. Look at the renal profile. Look at the dosage and frequency, especially in older age and low body weight patients. Switch to subcutaneous morphine if the patient is not able to swallow. As I said, morphine has a very wide therapeutic range. Now, there is no ceiling limit to the amount which you can give a patient. This is very important. You can, for Brufen, you will be able to give 400 milligrams 3 times a day. For paracetamol, you will be able to give 1 gram 4 hourly. But for morphine, the beauty of the drug is that there is no upper limit. You can give up to 3,600 milligram a day if a patient can tolerate it, if you have titrated it properly. Addiction, I have told you, it rarely occurs in this patient population. And even if a patient does have a history of addiction earlier, they are entitled to good pain relief. Please remember that even patients who have been addicts in the past, who have a history of addictive behavior, should get good pain relief. But you have to be careful. You have to supervise properly. You have to screen patients for risk factors, for alcohol and nicotine abuse. Have psychologists, psychiatrists in your team who can help, who can supervise, who can follow up and assess this high-risk behavior. We can ask them to bring back their medications, check whether they've actually taken, have a family member looking at them, have a team member looking at them more carefully, but we do not prevent them from getting access to analgesics. This is an important term to remember: pseudo-addiction. This is iatrogenic syndrome of behavioral change because of inadequate pain relief. And just like a patient becomes, body becomes used to it, the tolerance is there. So you have to remember that a patient may have progress of the underlying disease because of which he's asking for medication. You may have to increase the dose, but it's not actually psychological addiction. Addiction is something patient is taking for pleasure. Here, the patient asking for pain relief is not for pleasure. So that is the basic difference between addiction and pseudo-addiction. Some conditions may be very difficult to treat: neurological pain, bony metastasis, incident pain, and breakthrough pain. So I have listed these here, but we will not go into the details of all this. I've put them on the slides for you. You will get the presentation so you can read them yourself. But you must remember that there are many things that lead to neuropathic pain, chemotherapy being one of them. And neuropathic pain, even in patients who have been treated earlier, even 20 years later, it can be a problem because of neuropathy. Then pain in HIV, again, polyneuropathy, sensory polyneuropathy is a very common problem. Then other conditions, malignancies, stomatitis, all of these can lead to a lot of pain in HIV patients. Bone pain is an entire topic in itself, and almost half of patients have cancer-induced bone pain. It's very difficult to change, to treat, but we must remember that Cochrane reviews have showed that for patients who are in palliative care, shorter courses of radiation can be as effective as the longer courses, because it's difficult for this patient population to come for radiation again and again. For them, NSAIDs along with opioids, gabapentin, pregabalin, and bisphosphonates form the basis of management of cancer-induced bone pain. And an important thing that I would like to talk about is breakthrough pain. So breakthrough pain is something that happens because of sharp peaks of pain in between the pain which is otherwise controlled. So patient may have good control through the day, but in between, because of activity, patient is coughing sometimes, or spontaneously, patients will have sharp peaks of pain which start within, say, half a minute, go up within 2 to 3 minutes, and then come back. So how do you treat these? You cannot give injections. Voveran injection will take an hour to work. Morphine oral will take some time to work, and you cannot keep on giving IV doses of morphine. So what is required in these patients is the lollipops I showed you, the lozenges, OTFC. Transmucosal fentanyl is the drug of choice. Otherwise, we use 1/6 of the normal opioid dose that is used for breakthrough pain. Supposing a patient is taking, say, 30 milligrams of morphine a day, so 1/6 of that dose is what we give for breakthrough pain. It can be incident pain because of activity, patient having lung cancer with meds, walking around, and that bony meds are causing the pain. Patient is having cough, that is causing the pain. Patient wants to go to the toilet. Bladder spasm is causing the pain, or when the 4 hours of the morphine dose are ending, that is causing pain. So end of dose pain can be there. Or it can be unexplained, spontaneous exacerbation. So this was all about opioids. What are the other therapies we can use? So as you saw on the WHO ladder, we continue with supportive therapy throughout. So whether you are giving step 1, step 2, step 3, these are things that help us in supporting the patient on any step. Physiotherapy, transcutaneous electric nerve stimulation, cognitive behavior therapy, distraction techniques, relaxation, deep breathing, guided imagery, complementary therapies, art therapy, music therapy. These are things that help us to control the pain at any step, and they can be tried if available. Procedural pain, I will briefly mention. Procedural pain is very common in all our setups, whether we are in primary care, secondary care, tertiary care. Invariably, I have seen children howling with pain when they have to go for tests, and they become so scared of coming to the hospital. This may not be related only to palliative care patients. This is something we must remember for all our patients, especially pediatrics and women. Procedural pain. And for children who undergo repeated lumbar taps for leukemia, for chemotherapy, it's really a bad experience because, considering the number of patients we have, the way our staff is not trained to think of these things, we must be very, very sensitive to the fact that children will fear coming back to the hospital. It gives them nausea, it gives them palpitations, it gives them a horrible experience throughout their life if the pain is there for when they come for tests. So explain to the child, ask them whether they want any of the parents to be present. Please make sure your staff is not holding their legs and arms and putting them down forcefully on the bed, which is most often what they do. The child is howling inside, the mother is howling outside. It's not a pleasant experience. So please explain, make the child comfortable, make the mother comfortable. You can simply have the mother sitting with the child in her lap, or the father sitting with the child in his lap when you are doing a procedure. And contact with the caregiver is very comforting for small children. No negative restraining is there, it should be there, and reduce the number of people inside if possible. Also, there is a beautiful drug called IMLA, that is synthetic mixture of local anesthetics, which can be very helpful. You apply a thick 1 centimeter square. Supposing you have to take a sample from here, you just apply that 1 centimeter square thick layer under an adhesive dressing for 40 minutes. You can even do ear piercing without pain, let alone a simple lab test. It's a beautiful drug. I think we must all have in our institutions. It's beautiful. And for a child who's having a more invasive technique, please do go in for anxiolytics and sedation when you are doing that procedure. Lots of myths. Reassure the patient. Please go through them, read them, and then accordingly reassure when you're in your practice. And before I end, I would just like to share this little story with you. This patient here we have is, if any of you have been to India, IPM, that is the Institute of Palliative Medicine in Kozhikode. This patient was there who used to run the canteen. He was diagnosed with a giant cell tumor at 21 years of age and had many surgeries, lost his employment. He was a widower, had to send away his children to the hostel because he couldn't take care of them at home. 3 children were there. And then the pain clinic there started him on morphine. It was a recurrence he had, then slowly progressed. Morphine was increased to almost 1,000 mg daily. But even in spite of that high dose of morphine, the people in the staff in the pain clinic were able to, get volunteers to collect donations for him. And they started this little canteen for him near the pain clinic, where he could sit in spite of being on morphine, not sedated, earn his livelihood and earn enough of his livelihood to get all the 3 children back from the hostel, take care of them, and get them settled in life. So as you can see, this palliative care is pain management is not just about the physical pain, it's also about rehabilitation. It is also taking care of the family. And this is a very beautiful example of that. So I would just like to leave you with this last slide that all of us healthcare workers have this, we are very blessed to have this opportunity to serve our patients, to take care of them if we can. And if we can take care of the pain that they have, whether it is physical, it is psychological, it is emotional, it is spiritual, then we are indeed doing blessed work. So thank you very much. And now I think we have a case presentation from one of the participants. So I will stop sharing my slide and thank you very much for your listening. If you have any questions, I don't know, Sridevi, we will have to tell us whether we will take questions at the end or we take some questions and then go on to the case presentation.
Ma'am, let us take some questions for the timing. I think we already have one question there. I think it's from Christine Sivara. I believe the question is what is meant by the clock?
Okay, so would any other participant like to tell what they understood by the clock? Did anybody understand what means by the clock?
We have to follow the regular timing.
Yes.
Along the clock.
Yes, Dr. Varsha, thank you very much. So the basic guideline when we do this pain management with the WHO ladder is by the ladder, that means using the WHO ladder, by the mouth, that is using oral medication, by the clock means round the clock medication. We do not do SOS medication because the pain is there all the time. It's not going to go away. Patient is not going to heal. It's not an injury. So round the clock medication, not to miss any of the doses, and individualized to the patient's treatment. So I hope that is clear, Dr. Christivi. Is the question, a person who asked the question there, I hope they've understood. I'm sure they have. Okay, so any other question? Is spiritual pain and psychological pain same? Slightly different. Psychological pain is like depression, worry, fear, you're scared. And spiritual pain would be like, what have I done to deserve this in life? Why is God doing this to me? Did I do something wrong? Did I harm anyone in my life? Supposing a mother is having a 1-year-old child and she might be thinking that maybe I have done some bad karma, but what did my child do to be getting this pain? Or is it my karma which is hurting my child? So losing connection with God, losing connection with your meaning in life, that is spiritual pain. And yes, you can say that in a way, spiritual pain is also a part of your emotional pain, but we define them separately. So Dr. Harsha is asking, I'll just go back to what the question was. Morphine is first choice. Will fentanyl act after a patient is exhausted with morphine? So morphine, we say, is the first choice because we have more experience with using morphine, and morphine, as I told you, is the normal release morphine acts for 4 hours. So when you are starting a patient on the drug, you can titrate. If the patient is developing side effects, you have enough time to stop the drug, to change the dosage. But fentanyl, it acts to the skin. It's a transdermal preparation. The skin preparation of fentanyl takes 12 to 24 hours to both act and to also go out of the body. So we do not use it for titration. But once the patient's dose we have calculated, supposing a patient is having good pain relief with 60 milligrams of normal release morphine, then we can convert it into the nearest dose of fentanyl and we can give it to the patient. Okay, some patients may have radiation proctitis and frequent stool passage. So will fentanyl act after a patient is exhausted with morphine? I'm sorry, I didn't understand that question. Patient is exhausted with morphine. Can you please ask what you mean?
Actually, ma'am, I wanted to ask that morphine is a very strong drug. I thought that fentanyl, I was not thinking about fentanyl patch. I was thinking about IV route of fentanyl. So I was asking, okay, if morphine is such a strong drug and if it is not acting in that patient, then can you give fentanyl? Because I thought that fentanyl is a less potent than that of morphine.
Okay, so we will go back to this. You can go back to the slides and see. Actually, you know, there are two things. There are two parts of your question. First of all, morphine does have a ceiling. There is no ceiling limit. You can give as much as required. Just see the side effects. Number two, as far as potency is concerned, fentanyl is 100 times more potent than morphine. So you just have to look at the side effect profile. You have to look at the renal function. There may be patients who have a renal dysfunction. For them, fentanyl is the drug of choice, right? So we can start fentanyl in them just after titration. But yeah, you can just change the opioids between the families if you feel that one drug may be better, but it has nothing to do with the total amount of the drug. Is that okay?
Yes, ma'am. Thank you.
Okay, so is it okay to jump the pain ladder from 1 to 3? Because some of the patients don't tolerate tramadol and it's also expensive. Yeah, you can, but the thing is, see, in children, as I said, we don't use tramadol. For them, for severe pain, morphine is recommended. So this is an arbitrary thing. It is not a hard and fast rule. You have to see and you have to individualize the treatment. But yes, cost is very important. And the renal and liver profile of the patient is also important. So you can start morphine straight away with a lower dose. Do we give laxative such patients? We give laxative to all patients on
I think that's rest of the question that she asked previously. Some patients may have radiation proctitis and frequent stool passage. Do we give laxatives for the patients?
Not when they are having that proctitis, active proctitis. Once it's settled down, only then.
Definitely, we will stop laxatives when the patient is having diarrhea. So
yes,
and we can wait, and if once the diarrhea sets in, we can restart.
How about making assessment of pain in an unconscious patient? Very good question. There are other ways in which we can assess, like we do for small children. You can see the body language, you can see the grimace, you can see their response to a painful touch. So there is a scale which you can use for the unconscious patient. If you need, I'll send it to Dr. Shripriya and she will circulate it to the people. What
there are multiple scales like flat scale, so which has the facial expression.
Yes, so facial expression, leg movement, activity, cry, and one more thing I don't remember offhand, but yes, there are scales for children and there are scales for adults also. What route to give 1/6 dose for breakthrough pain? Oral. We are talking about the oral route only at present. Does it mean that the maximum dose of morphine is more than 1000 mg for 24? It can be more than, depending on the patient. Most of the patients will settle with 600 to 800. But yes, there are patients who might need more than drug. So, but you have to keep in mind the side effect profile. So find a balance between the tolerable side effect and the pain relief. Patients usually will not aim for 100% pain relief. They'll be happy with the pain. If say there is 4 out of 10 patient pain is there and they have a reasonable amount of activity level, they are able to do their work. So they say it's okay, we can tolerate that much of pain, but we don't want to be sleeping throughout the day. So it has to be, balanced between the side effect and what the patient wants to do. There is no limit, but do we get handouts of these sessions? I think the Pallium team will tell that.
They will receive the PowerPoint illustration.
As and when Dr. Savita shares it with us, we
Of
will
course,
definitely.
in palliative care, we say that we have the right to copy. Okay. But only 2 things. Patient confidentiality should be maintained. And if there are any pictures, then we try to remove those pictures and send the PPT because the pictures may be copyrighted, So, but the material is for you to use, to read and to teach others. So very happy to share the presentation.
So there's
Please
a question,
explain.
I'm sorry, please.
I was just reading out the questions there. Please explain EMLA. EMLA is a short name for this local anesthetic mixture that we used. It is eutectic mixture of local anesthetics. So if you go and look, it's a cream. It is cream, 35 mg and 50 mg packing you get, and you can use it for you can use it on the skin for tests when you do invasive procedures. As I said, ear piercing also, and for spinal taps also. How do we adjust?
Sorry, we usually prefer to use it before IV cannulations and
Yes.
even aesthetic tapping also, so that the patient.
Very true. Not only for children, we use it for our very hyper sensitive women patients also. How do we adjust morphine dose for a patient in severe pain, like in a sickle cell crisis, especially in the first few hours of admission? I think for that we have to use IV morphine. I have not put the slide for IV titration because I didn't know whether I was supposed to do that or not. But we will send you the handout of how to do an IV titration. Opioid can be used in cardiac and renal patients where NSAIDs are contraindicated. Yes, of course you can use, but you have to be careful of using morphine in renal dysfunction because the metabolites can get accumulated and lead to toxicity. So for patients with a renal problem, fentanyl is better. So we generally titrate in 1 or 2 days and then switch over to fentanyl. Is that right, Dr.?
Yes, ma'am.
Yeah, I'm forgetting your name, please. I'm sorry. Okay. So would you like to add anything there?
Nothing, ma'am. There'll be a session on non-cancer palliative care. So this topic will be covered that. So, ma'am, I think we missed one question by Dr. Priyanka saying, what is the role of buprenorphine?
What is the role of?
Buprenorphine.
Buprenorphine in palliative care, we don't use so much, but yes, you can use for a patient who is having comorbidity with osteoarthritis, for example. And the thing is that it has a sealing effect. So one has to be careful on using, but when we talk about palliative care in general, so we talk about morphine oral as the gold standard. But yes, other drugs are there. And because of time limitation, I'm sorry, we cannot go into everything. But yes, you will get study material and you can use, you can, read it. And when we have the next session, whoever is the person taking the topic, it may not be me, it may be somebody else, but you can come back with your questions about those things again. Is that right?
Yes, ma'am.
They can ask whoever faculty is there. Any faculty for any topic you can ask.
Actually, ma'am, we are presently running one online question bank as well, wherein if the time limit is there and participants are not able to ask the questions during the session, they can post their questions in the Google Sheet. That will be shared with you, and then the feedback, whatever we will receive from the faculty, and will be shared in the spreadsheet as well, so that everyone has access to it. So we are launching that as well.
Okay, so one question is, can morphine be used in gallbladder CA post-surgery? Of course, morphine is, it can be used, and it can also be used for post-operative cases. In fact, we should be using for post-operative cases. We don't use it enough.
Okay, ma'am. Thank you, ma'am. I think we can move on to the case presentation.
Yes.
May I call upon Dr. Diya Devsi?
Hello. Hello.
Yes, you are audible, doctor.
Yeah, okay. Good evening, everyone. I'm Dr. Diya Devsi, and I'll be presenting the case today based on the topic management of pain. So the patient is a 51-year-old female, and the diagnosis is plantar fasciitis with calcaneal spur. The presenting complaints were intermittent stabbing pain over both feet since 6 months. And she also had difficulty in walking and standing on her feet since 4 months. History of illness, a 51-year-old female patient who's a teacher presented with intermittent stabbing pain over heels and plantar aspect of both feet since 6 months. The pain was initially dull in nature and progressively worsened. There was associated difficulty in standing on her feet and walking. The pain decreased during rest, but she felt that it worsened when she got up after a period of rest, like in the morning. There's also a history of being on foot on both her feet for long hours as part of her job. And there was no history of any trauma, infection, or surgery. She also had a history of knee pain in both her knees 4 years back, for which she had taken NSAIDs and Ayurvedic massage treatment. And after this, her condition had improved. She also has hypertension for the last 6 years and is on medication. On examination, her general examination was normal. She was conscious, oriented, and cooperative. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or edema. Her BMI was 33.2, which comes under the classification of obesity class 1. Her vitals were all normal. Systemic examination was also within normal limits. The local examination of both her lower limbs on inspection, appearance was normal and there was no deformities or gait disturbances. And palpation, there was no local rise of temperature, but upon palpation of the heel and plantar aspect of feet and the Achilles tendon in both right and left lower limbs, there was tenderness. Her range of movements were also normal in the ankle joints, and distal pulsations were also felt normal. So the treatment, so the investigation that was done was an X-ray of both the lower limbs, ankle and foot. Lateral view was taken, and you could see at the calcaneal base that there was a prominent bony projection which was small. Psychosocial aspects. So the patient is a 51-year-old female teacher who spends a great part of her day on her feet as part of her job. And she's also a financially contributing member of her family, which includes her husband and 3 children. So due to the pain, she found it difficult to stand for long hours, and her job required her to stand for long hours, and this started affecting her work. And as part of her daily exercise routine, she used to go for evening walks, and she had to stop this because of the unbearable pain. And this affected her exercise pattern. So, as part of her hypertensive management, she was taking medication, but also lifestyle diseases had been suggested. So, this part of her exercise pattern was affected. And her quality of life at home was also affected because after returning from work, she had to rest for the remainder of the day and could not contribute towards the household activities. And so overall, she faced severe pain, which caused her productivity at workplace and home to decline. So the medications that she took included mainly conservative treatment. So she was advised initially to take ibuprofen for a week for pain management. And she also mainly underwent physiotherapy treatment for 10 days. And this helped her condition. Both these treatment helped in improving her condition significantly. So the treatment focused mainly on the soft tissues of her feet and stretching exercises in order to relieve the pain. And she was also advised on properly fitted footwear, which provided adequate support for her feet. She was also advised on the need for lifestyle control to reduce her weight, as the condition was thought to be caused because there was increased stress on her feet. And she also continued taking her regular hypertensive medication. So the main concern included ensuring pain relief with conservative management and not letting the condition worsen, which rarely would have required a surgical management. And the patient's quality of life and work was being affected, which began affecting her emotionally too. And the patient was overweight, which was also a risk factor for this condition. And earlier, for her knee pain, she had taken NSAIDs, which had resulted in gastric problems. So this time also, it was since she was taking an NSAID, it was made sure to be taken with a PPI. So the summary of the case is a 51-year-old female teacher complained of intermittent stabbing pain in both feet over heel and plantar aspects in 6 months, which progressively worsened. She had a history of standing for long hours at work, and the pain worsened on doing any activities while standing or walking and decreased on taking rest. There was no history of any trauma or surgeries. On examination, the patient appears well. She had a BMI of 33.2. There was tenderness over the heels, plantar aspect of both feet, and Achilles tendon, which restricted her mobility. And X-ray lateral view of ankle and foot of both lower limbs showed well-defined bony projection on the base of calcaneus. She works and is a financial contributor to her family, but the pain is affecting her at her workplace. It has also affected her quality of life at home, and she was treated with ibuprofen for a week along with physiotherapy for 10 days. She was also advised on using well-fitting footwear with adequate feet support and controlling her weight. The conservative management controlled her pain significantly. So the discussion points based on the patient story is, how can severe persisting pain affect one's quality of life and emotional well-being? So in this patient's case, she used to work as a teacher. So her workplace, she was used to standing for long hours as part of her teaching. And so since she wasn't able to stand for longer periods of time like she was able to before, this started affecting her work and she had to take breaks in between. And so at her workplace, it was affecting her. And since she wasn't able to do the activities that she used to before, her emotional well-being also started getting affected. So another question is, can a patient's complaint of pain be considered any less important because it isn't at the end stage of their life? So considering this patient, it might seem like it's just a pain of both her feet, which can be controlled. But for this patient, any amount of pain that she is suffering was affecting her life. And even though it wasn't at the end stage of her life, it was a pain that she was being put through. So for her, it was very difficult to cope with, and she had to take treatment for it. And can symptoms of pain be ignored just because it is bearable? So this patient initially, since the patient could bear the pain, she hadn't taken treatment. So after 6 months, pain had progressively worsened, and then she had taken treatment. So I think that the pain shouldn't be ignored. If it was considered in the initial stages itself, she wouldn't have had to go through such extreme levels of pain. And what are the measures could have been taken in managing this patient? I think the management given was NSAIDs and physiotherapy treatment. So it adequately helped in controlling her pain. And I think her family could have also helped in with her pain, with controlling her pain, because they would have definitely helped around the house and given her support to get through with the pain initially. Thank you.
Thank you, Dr. Dian. So now let us hear from other participants about these discussion points. So let's take the first question. How can severe persistent pain affect one's quality of life and emotional well-being? So other participants, kindly give in your inputs.
Hi. So basically, I would like to add that pain is not just a symptom, it is like when we take some effort to breathe, the pain even lets our conscious gets affected by a larger means. And yeah, definitely it affects the emotional well-being also, because we are unable to enjoy, which is the main purpose of our lives, that the definition of health says. So we are unable to enjoy whatever we do, and definitely, and if the pain persists for a longer time, we lose our appetite, we lose our weight. So the general well-being is lost, definitely. And we, as I said, we are unable to participate in any part of the society or the family. So yeah, severe persisting pain can definitely affect the quality as well as emotional well-being.
Thank you, Dr. Tinu. That was a very good answer. So can we have some more inputs?
Since she could not carry out her day-to-day activity in both in workplace as well in personal life, it causes her relationship also in both in family and workplace. Maybe she may face like blaming or like nagging this one. So that also emotionally she will be upset as well. She cannot be active. So that also restricts her movement and causes emotional upset also.
Okay. Thank you, Dr. Premlata. Any more points to be added?
Hello.
Yes, sir, you're audible.
Yeah, no, along with all this psychosocial problem, there can be a financial problem also. If she is not able to do her routine work, then that can lead to the financial problem also. She may not earn her daily uh, wages, and she may lose. She may have the financial problem also.
Exactly. Sir. So what I would like to do is to break this pain, look into this topic pain and the total pain concept. Let us break it into the physical, psychological, social, and spiritual pains. So if we could break it into it, so the pain itself is causing a very physical issue for her. She might have undesirable effects of the treatment, which have been already explained. That she had a history of gastritis from the NSAIDs, which she had to suffer right now because of the NSAID. The insomnia, the sleep issues that come with the fatigue. So these physical part can cause the pain. When it comes to psychological issues, she might be having some the fear of pain, the pain worsening when she walks, she might have anxiety, the fear of being disfigurement. She is trying to limp, she might be limping with the pain when she walks. So what others might think that could be something that affect her. She might be anger. Anger could be there. That there is no much relief. If there is, even if she takes some treatment, no relief, then anger can happen. Even she can go for depressions. When it comes to social factors, like as you have been explained, there could be worry about her family and finances. Yes, she might be finding it difficult to work. So that could add to it. She is unable to perform well in her job. She loses a role in a family. She might not be able to do a normal course, and she loses a role in family. So feeling no one might be acknowledging her pain, so she might feel abandoned, like isolation. Even spiritually, she might be asking why this happened to me. So all these are several areas where this pain can affect a common well-being. Anything more to add, Dr. Savita? Would you like to add something?
No, I think all the points have been covered nicely. So we can go on to the next part.
So the next question, can a patient's complaint of pain be considered any less important because it is in the end stage of her life? So I think we can combine the next question also. Can symptoms of pain be ignored just because it's bearable?
Hello.
Yes, Dr. Anjali.
Since it is affecting the patient's quality of life, I think every pain that the patient suffers through must be addressed, because they have to lead a comfortable life and do their daily work and their job or whatever is required to get through the day. So any amount of pain that is causing a debilitating condition for the patient should be considered important and treated accordingly.
Thank you, Dr. Anjali. Anyone would like to add more to that?
Sir, I would like to add that any pain, if it is not addressed at the immediate point, it can convert into chronic pain. So we should treat the pain as early as possible so that the patient does not go into that cycle of having chronic pain.
Thank you, Doctor.
Hello.
Yes, ma'am, you're audible. Please continue.
Hello. Yeah, I would like to add something. We have a habit of generally in practice, we have a habit of adding a NSAID or something for pain relief SOS basis when the pain increases. When patient is actually suffering from pain, we have to give it round the clock, and most of the time the habit is to give SOS. There is no question of SOS when the patient is already in pain. Most of our postgraduates I have seen in my during rounds, they keep it SOS, and they always forget that relief of pain for a person is very important to have a good quality of life. So that's what I want to add here.
Thank you, Dr. Veena. That is a very valid point. So that was one of the points that Dr. Savita covered. So
yes,
we are assured we have to assure there is round the clock analgesia for the patient. So when we prescribe a medication, we must know the pharmacokinetics of the medication, and so that the dosing should be adjusted to the patient. So he gets a pain relief throughout the day. Like when it comes to paracetamol, the action lasts for 4 to 6 hours. So the dosing will be adjusted every 6 hours, not a BD dose or an OD dose or SOS dose. So he gets when we give 6 hourly paracetamol, the patient gets a relief throughout the clock. Any more?
There is no bearable or unbearable pain like that, because the patient, they starts complaining, only it becomes unbearable. They don't complain, or they don't seek advice as long as they can tolerate it. So we cannot tell, okay, whether it is, we cannot comment on the other person's pain tolerance or bearability. So I think whatever they tell, we have to treat them.
Exactly, ma'am. So what that said, it's subjective. Pain is a subjective thing. Pain is what the patient says it's worth. So even the IASP, so let me add something to it. The IASP, the International Association for Study of Pain, when they collate that, there is absolute correlation between observed behavior and patient reports of pain may be poor as individuals' tolerance of pain varies. So each patient will each person will be tolerant to pain at various levels. So something that might be hurtful for me won't be hurtful for you. So the pain is a subjective matter. It is what the patient says it hurts. Anybody wants to add anything more?
Dr. Nirali has raised her hand.
Dr. Nirali, you have raised your hands. Do you want to add something?
Yes, I just wanted to ask this question, maybe unrelated to this, but like we said, that pain is subjective, and how to measure the severeness of the pain, because the hospital that I work in, it's in a rural area, it's in a tribal area. So if I say that, okay, on a scale of 1 to 10, 10 being the worst pain that you've ever experienced, where would you put it? Most of the patients are not able to communicate that in that way. So as a physician, how can we judge how severe the pain is, if that makes sense?
Can I
Dr.
answer
Savita?
that?
Yes, ma'am, please.
So, Dr. Nirali, very nice to know that you're from a peripheral area, just like I am working in a peripheral area. So the thing is that we use the rupee scale there.
Okay.
You know, patients are very used to, they all know how to buy vegetables. They all know how to use the rupee for everything. So just ask them on a scale of 1 rupee, how much out of a rupee is your pain? Is it 25 paisa, 50 paisa, 75 paisa, or a rupee out of rupee? So they'll be able to tell. Even the ladies from the village can tell you very much. Easily they can tell. Yeah, otherwise use the faces scale. Both of them can be used.
Okay, thank you, ma'am.
Once you start using it, no, I just put in a question here that how do we assess this patient's pain? We have done everything here, Dr. I think Divya presented, no? So, but for assessment, we will have to ask how much is your pain? Where does it come from? Where does it go? What is the time? What increases? What decreases? All of those things. And yes, for any illiterate patient, for any uneducated patient also, you can use that faces scale. But whatever scale you use, you try and see whatever is feasible, but do have a baseline assessment because it will help you in 2 ways. It will give you an idea of the effect of the treatment. It will give you an idea of how much the drug is giving them relief and for how long it lasts. So it will help you to titrate your treatment better. Yeah.
Sorry, I just a follow up to what you said, ma'am. Another thing that I face in my clinical practice is many of the patients, they don't come back for follow up. Sometimes it's really hard to then when the pain becomes very, very severe is when again they'll come after like 1 or 2 months or after a significant amount of time. So in that case, how can we administer certain medication so that there's no question of it being tapered, or we can make sure that the patient is being treated adequately? That was another follow-up question.
So in most of the cases, patients are being followed up either, I'll have to stop my camera because it's not, they are being either followed up on phone or we have home care visits. So for each place, one has to work out whatever is most feasible. You have to find something which is locally feasible. So it might be possible to, somebody might be having a telephone, you might be able to call them, find out how they are doing, have a video call. During COVID, when there was lockdown, we were doing a lot of our follow-ups on video call. And whether people are able to come or not, I think most of them would have some kind of connectivity to a phone, whether they own it or somebody in the family or friends has it. Also, you can find out if somebody is trained, there may be an RNP, there may be an ASHA worker. We can coordinate with them. Please request them that we will, please go to their house and tell us how they are doing. Something we can work out locally. It may not always be possible for the patient, but yes, when initially starting opioids, it is good for them to come back. But once the patient is stabilized, we do give them medicine for 15 days, 20 days, even for a month. In AIMS, we give for a month. And we make sure that patient is followed up on phone. Sometimes we allow the attendants to come and take their medication if they're not able to come. But yes, we do video calls to see if the patient is really alive and the medication will not be misused by anybody else.
Okay.
I think community involvement would play a good role in this condition, such situations. So you can find someone, if you are able to find someone within the community, so you can have a contact with, or like ma'am said, we could involve some RMPs or ASHAs. That would be helpful in such situations. So let's go to the last question. What other measures could have been taken in managing this patient? Inputs, please.
Hello, I am Dr. Shalu. Sorry, my video is off because here it's very heavy raining and thunder.
Okay, ma'am, please.
This lady is a 51-year-old and she's a working lady. So her calcaneal spur can be managed by surgery if possible. So if she is not willing to do the surgery, then is it advisable to give her long-term NSAIDs or any opioids?
So considering this as a non-cancer pain, I wouldn't suggest to give opioids right away. And that too for
one
long
hand is
term.
raised, but it's called Samsung SMT 500. So we don't know. Yes, please.
I'm sorry, it is me.
Please go on. I'm speaking on behalf of Pallium. Go on.
I had already shared a message over chat, but I think she was too busy to, she was too concentrating on the class to check that message also.
Can you say your name, ma'am?
Ma'am, I'm Dr. Shahina.
Hello, Dr. Shana. You wanted to say something, please.
Sir, based on the questions that you asked, what are the other measures that can be taken? Or they can give hot massages, hot baths, a mix of physical touch, like cold massages, hot massages can be given to alleviate the pain temporarily.
Thank you, Dr. Shana. So, yes, then coming back to Dr. Vinandya, you have raised your.
Okay, thank you. I want to try to answer the question. In this case of patient, the pain will recurrently appear and even worsen. So the patient would need such medication taken orally, such as NSAID, and sometimes such intervention like steroid injection in my country, in Indonesia, should offer to the patient and given in the base of calcaneal side then it can help to decrease the pain intensity. But as the disease trajectory, the patient would need several time of injection, like maybe for 2 or 3 months. Thank you.
Thank you, doctor. So when it comes to non-cancer pain, I prefer to choose medicines to preserve the independence and minimal long-term side effects. So I'll be functioning, we should focus more on the functionality and rehabilitation. Opioids can be avoided as much as possible as first-line pain therapy or for long-term treatment. So for her, when you consider for her, so her main concern is the pain is due to, one of the reasons is Achilles tendon stretching. So we can go for physiotherapy where Achilles tendon stretching exercise can be advised. Then the first thing that we have to correct is lifestyle modifications. Her weight reduction has to happen. Her BMI is 33, which is obese category. And this weight reduction has to be there so that further pain recurrence can be prevented. So lifestyle modifications can be advised, weight reduction, then footwear modification. Most of these patients will be having a flat foot issue. So they will need a proper footwear which can support their weight. Like NCR was the ones with NCR, so individualized footwear can be suggested for them, especially if she's a working woman with a long-term standing type. Then there is something that we can give for tipping. It's a non-pharmacological method, something that Dr. Shahana, something similar to Dr. Shahana said. It's called a contrast bath. That's something a physiotherapist commonly use. They will ask the patient to dip the affected leg in hot water, which is tolerably hot for 5 minutes. After that, dip into cold water for 1 minute and repeat this at least thrice at a time, like over a period of 20 minutes. They put their leg for 5 minutes in hot water, 1 minute in cold water. So this sudden dipping will help in vasoconstriction and vasodilation. So some pain will live. This is not a permanent solution, but a temporary solution. They can have some relief. And local steroid injections at the site can be given if it is not controlled by NSAIDs and other pain medications. Triamcinolone injections are given. PRP injection, I am sorry, I don't know about that. I think we'll have to look into it. The PRP injections are helpful at this site. Then, yes, of course, surgery would be, may be needed for her. So that she has a good quality of life for the next time. And we also have to assure the other support, like all other issues. Physical issue having, we have to give a psychological support and social supports, and spiritual issues has to be also considered. She might be needing more support from her family. Like she might be happy to have some help from her family members in doing a course. Then she might need much support from colleagues at the school. At least she can sit and teach. Being willing. So multiple factors we can help to manage the pain of the patient. Anything more to add? Anybody want to add anything? Dr. Savita?
No, I think you've explained everything very nicely. So
thank you, ma'am.
Mayur Joshi has a question, Savita madam, regarding pain management, but I don't know whether I'm audible. You can try, Mayur.
Or you can put the question in the chat.
Dr. Mayur, you can type your question if you want. Question is too long, so try speaking. I cannot see you on the screen.
Dr. Mayur, your mic is enabled. As far as I can see, only your video is disabled. So
can you try speaking up?
Or else we can try the question bank as well. Maybe you can share your question in the link which I'll be sharing hopefully by tomorrow, and then I can get in touch with Dr. Savita and get back to you. Hope that will help.
Okay, and I will send my PPT also, minus the copyrighted pictures. I'll send it. They can see, and if there are any other things that they need, I'll be happy to help.
So I think we can end the session for the day. Thank you, Dr. Savita. Thank you all the participants for the active participation.
Thank you. Thank you very much.
Thank you, Dr. Savita. And it was really very good news for us when you said that you will be available for the entire session, because initially you had said you will have to leave for one webinar. But I believe that that would have been a loss if you had that webinar in place. So thank you so much for joining us and being with us for the extended 15 hours. And we do look forward to have more sessions with you like this in future as well. Thank you everyone for joining in, and we do humbly request everyone to be more interactive, because we are bringing in eminent faculties, and we would request every one of you to make use of this opportunity to learn palliative care. So with that positive note and an assurance that we'll again meet in another day with a different topic and an eminent faculty. This is Sri Priya along with Dr. Savita Butola and Dr. Arjun Devarajan signing off from the Tips Eco Hub. See you in the next session. Till then, everyone take care. Keep spreading happiness. Bye-bye.
Thank you. Bye-bye.
Thank you.
Thank you. Bye-bye.